Right. So, can you hear me?
Yes, yes, sir.
Very nice. So, can see the PPT also.
Yes, sir.
So, I see many of my students also. I see many new students also. And so, good evening to one and many. So, many of you have already passed, I can see. So, thank the organizers. Somehow, I figured in their radar that probably I can do justice to this topic. So, this is the topic of duplication, one of the most complicated and quite a surprise. And how are your lectures being conducted? You are doing a one way or just a two-way conversations?
Sir, initially we will complete the class and at the end of the class there will be questions to answer.
So
Whoever
now
has
we'll change for this thing. So I'll invite questions right away. So you'll ask your questions and let's do it um, as I progress. If you have doubts, please ask, because many times some things can be clarified right and then and there itself. Right. So for all those who do not know me, I'm a professor in pediatric surgery. I did not give the name of my institution, but I belong to MAMC. And the chapter today allotted to me is by all means, you will be finding questions for long questions, short notes in DNB, and practical maybe lumps, yes, PUJ obstructions with lumps, but definitely going to be your lifelong career challenge. Right. So to start with this, I would want that everyone knows that you people are all wise by the virtue of where you have studied and come. So I intend to make all of you wiser with this lecture, but then you have to do a little bit of your self studies, and then uh, you will be the wisest of all. This is not a very straightforward topic. I am not going to cover the operative part, right? So as you can know, that's a very big thing. So operative part I won't, but definitely my doubts when I was a student, what were all the embryology doubts and what happens, how the embryology works, and there are multiple scenarios which can be there and how to go past them, right? So first of all, obviously embryology will be important. So here can I ask? So feel free to answer. Paramesonephric duct is also known as what? I see Harsh and others are also there. So the organizers can also. Paramesonephric duct is also known as Lakshmi and all are there. So what is the other name of paramesonephric duct? What is the fate of paramesonephric duct?
Mullerian duct, sir.
Correct. So this is nothing but the Mullerian duct. It is going to form the female reproductive tract. It is important to know this because what we are going to deal with today is the mesonephric duct, and the ureteric buds are going to be given from this. So mesonephric duct is the Wolffian duct, which is going to form the male vas. So there are buds from here, and the whole spectrum of gamut of problems will start from where the bud starts and where the bud one or two, whether it branches or not. Somebody has to put the speaker voice off. Yeah, it's good, right? So very important. So ureteric bud will start. It will go and meet the metanephros. This interaction is very important, right? And why this interaction is very important? Because when it interacts, it is going to form a normal parenchyma. If the ureteric bud does not interact well with the metanephros, we end up having dysplasias, and that is a part and parcel of duplications, right? So the differentiation of the metanephros is triggered by this molecule, this system. And mind you, many of the institutes are doing a lot of studies. They are doing thesis on BMP4. So BMP4 is also one of the causes and trigger factors for duplication. So this is more for the theoretical. And many of you, I believe, are doing thesis on urinary BMPs and then correlate with PUJ obstructions and other things. So just a little bit, all of these slides can be very quickly put it into a answer for a question. If you have any doubts, you can ask me. So very important thing, right? So this is what we are talking about. I'll put it into a laser pointer. So this is the mesonephric duct. One place the ureteric bud will start. It will go and meet the metanephric bud, and then it will start it forming a kidney. The part which is distal to the bud, it is the common excretory duct, and this will be slowly absorbed into the developing bladder, and it's going to form part of the trigone, right? So this part is going to form the trigone. This embryology is important because ultimately what will happen, whether it will reflux, whether it will obstruct, it all comes from here. So please do understand this. So this is the normal position. Suppose this part is all proximal, this part is all distal, right? So if you have a bud which is distal, so what will happen? Distal, there is a bud, and this part is all getting absorbed into the bladder. The ureter is budded very away from this bladder, developing bladder, and slowly the ureters will be come down, and this ureter, which is going to bud distally, proximally, is going to have a position which is going to be caudal, and this is the ectopic caudal ureter, and this is rightly called as the caudal ectopia. So caudal ectopia is with a proximal budding. Any questions over here? Right? In my exams, I somehow desperately marked it up, remembered it, diagrams. So if you have any questions, you can ask. And please remember that this ectopic ureter, wherever the location is, it can be in the bladder neck also. And in the subsequent slides, I'll tell you that if it's in the bladder neck, then it will be closed, it will be obstructed, and it will cause problems. So it can go as low down as into the prostatic urethra in males also. Suppose the bud is too proximal. Suppose this budding is, suppose here. So this may not even reach. This may open somewhere outside the bladder, somewhere here. And this may be a reproductive tract. And this is why the females can have two incontinence, right? So very important. So purpose of this slide is that the proximal buds will go caudal and they will be ectopic. Similarly, distal ureteric buds will quickly get into absorbed into the bladder, and they will go travel laterally, and they will form a lateral ectopia. So please remember it. If you have finding difficulty in understanding it, just you have to memorize it. It is important. These are from your Quran and different concepts. So if you have a ureteric bud which comes like this and then bifurcates into two, so this is what I'm going to tell you is going to be incomplete. But if you have two buds like these are going to cause complete duplications. So one single bud further dividing into two will form incomplete. But if the mesonephric duct has two ureteric buds, then they will form a complete uh, duplications. And as you can see, uh, it the dark one you can see is the upper pole, the lighter one is the lower pole. And because of this law, which is known as the Wiegert-Mayer law, there were two different personalities who have given this concept that since the vase is going to go down, so whatever the configuration is going to get twisted. So how does it get twisted? The upper one is going to go down. So this is upper and this is lower, right? So why this picture in Quran we have given? It shows that how close are the buds. If the buds are too close, then see both the buds going to be in the trigone. Do you see? Both the buds are going to be the trigone. This is embryology. But if the buds are further away from each other, distance between the two buds are further away, then the one you know already, the proximal one will go more caudal, more ectopic. So this will go here, and this will be the one which will be more caudal, more ectopic. So it all depends where it is budding and how much is the distance. This will be telling you whether at all it will be lying in the uh, trigone or not. Similarly, if one bud is too distal and another one is too proximal, then this is what happens. And please remember the ureters which are lateral and cephalic, they have more chances of VUR. They have less interstitial pores. This is important. At the end, I will ask you again. You have to remember this. Ones which are more cranial and lateral, they have a less interstitial course and they will have more VURs. Right? So with this, we start with a basic introduction. Everybody knows this. When the ureters are fused to each other, they are known as the incomplete duplication. If ureters do not fuse to each other and they open into the bladder separately, there will be complete duplication. And it is a known fact that incomplete duplications are more common. Luckily, they are more common. Right? Any questions so far? Anything which you would ask, want me to repeat?
No questions, sir.
Any questions you want to ask, you can ask me right away. Any patients you have seen. So far, it's not going to be clinical applications, but yes, this is quite straightforward. This embryology you must know. Then incomplete duplication. I should ask. Okay. So even we have Arvind also. Okay. So Arvind is no more my student, but anyways, any student who can tell me incomplete duplication, how do they present? So most of these patients will be asymptomatic and they will be just diagnosed because of some other problem, and they will be you have given them a investigation for a pain abdomen or an investigation for some other reason, and you find that incidentally there is an incomplete duplication, right? So question is, how do they ultimately, if they have to present and make a patient symptomatic, can anyone in this, out of 44 amongst you, can anyone tell what are the three ways how incomplete duplications can present? So they have three problems exactly. All of there are people who have studied for your exams, and so you can, instead of this chat, instead of me checking, why don't you open your mic and tell? It is very convenient. So what are the three problems incomplete duplications will ultimately present as? Right? And I suppose everyone has read this. So if they have to have a presentation, they will have a presentation like a VUR, they can have a PUJ obstruction, and everybody knows this. This is one of the favorites. Everybody somehow remembers this, and that is yo-yo phenomena. Yo-yo phenomena is uh, the Y-shaped ureters are there, and it's an anti-peristaltic reflux from one ureter to the other, right? And again, I'm going to ask you this. You have to remember in this, if you do not remember anything else, but you have to remember that PUJ obstruction is more common with the lower multi, right? Where is the ureter seal common? Where is reflux common? Where is PUJ obstruction common? These things you must remember. It will help, or it will help manage your cases, right? So these are the three ways how an incomplete duplication patient will present. And the treatment, if asymptomatic, then we do not treat them. If they are symptomatic, then the treatment will depend upon the function of the moiety. Therefore, so as a general rule, I hope everybody knows this dictum for renal cases, that we should not manage any renal case without a functional study. It may land all of you into legal problems, right? So we must have a functional study. So if you are think that you have posted a patient for surgery, so if it's a renal case, then it is more fair to know that have you done a functional study. The patient may be quite moribund, quite sick, in complicated UTI, unfit for shifting anywhere. Only those patients can be spared a functional study. But you must know that even in the worst of scenarios, even a patient who is unstable, blunt injury abdomen, even when you are suspecting a renal injury, even then also you can do an intra-op IVP. So you must know a fair idea that functional study is very important. And The length of the lower limb is also very important to ultimately decide what kind of management we should do. So these are the two things which decides in an incomplete duplication how their fate is going to be. So if I convert a Quran into a flowchart, then this is what it is. The function of the moiety is important. We have various ways to do functions. I'm sure your lecture series also has included those. So you know that we can do a radionuclide scan, and we find the function is poor. So if the function is poor, then nephrouretrectomy, we are talking about symptomatic patients. So nephrouretrectomy, we have to make sure that the lower ureter is taken up to the junction where it meets the ureter, upper ureter, and we must do a nephrouretrectomy. But on the other hand, if the function of the lower moiety is good, and mind you, I'm not only talking about VUR, I'm talking about VUR, PUJ obstruction, everything together. So if the function of the moiety is good, then we have to take consideration about the ureteric length. So lower ureteric length is very short, right? If it is very short, then Quran says that we can join both the pelvis, that is pylopilostomy. That means we are going to convert both the pelvis into one pelvis and let it drain into the upper ureter. We will have to uh, ligate, cut, and disconnect the lower ureter. We join both the pelvis, and that should suffice. But if the ureter is long, and we are talking about a huge obstruction, right? So we can go for a conventional dismembered pyeloplasty. On the other hand, if the ureter junction is very close to the bladder, then it is sometimes very prudent to do a ureterostomy. And the distal ureter is, because it is very close to the bladder, you have to separate them, or you have to, because even a common sheath reimplantation is very difficult if you do not have a adequate common ureter length. So in that case, you have to do a ureterostomy. This flowchart is a conversion of a paragraph in your Quran, also supported by Campbell. But this is by and far what you will do for an incomplete duplication. Again, I'm telling you, function is important, ureteric length is important, and this is how you land up into the treatment. And this will be, you will see day-to-day practices when you cut through your curriculum and then you are practicing. Then this is what you will have to give a due consideration on. We switch on to the complete duplication, and one may ask you the most common anomaly in complete duplication. Is it a PUJ obstruction? Is it a VUR? Which is the most common anomaly in a complete duplication? And without any problems, one should answer it as a VUR, right? Question is which pole? VUR in a complete duplication will affect which pole? So I'll take the question chat box later on. Nice. Very nice. So, yep. So VUR will be commonly the lower pole. So these lower pole, upper poles commonalities will be important at the end. They are also going to be your Viva questions. Plus your management of the patient depends if you already can guess or you have a very high degree of suspicion which pole. You must also know that VUR can happen in both the moieties also if both the ureters are very close to each other. So I hope everybody realizes that management of a duplication is very thoroughly based on high degree of suspicion, a good correlation over the anatomy, and you have a good investigation like MCU to know where actually the reflux is taking place. Most common is lower pole, but it can be both also, right? And please, again, I'm telling you that more the ureter is upper and lateral, shorter is the interstitial length, more is going to be the chances of UR. Most of these children will present with UTI. 60% is the incidence of presentation as UTI. And you have to know that in a setting of UTI, and if you find duplication, then MCU is almost mandatory. You have to do a good MCU because a lot of things, lot of treatments will depend upon a good quality MCU. Where is the reflux? What is the anatomy? Both sides or not? Which ureter? Any questions so far? Anybody who has had cases and they had problems and anything you want to ask, you can ask. right? This was our very favorite MCU picture, right, from our PG entrance days. So this is axis which is slightly deviated. Upper calyx is not seen, lower and middle calyx are pressed down. This is the drooping lily sign. So what all do we see in this MCU? We see a pelvis which is rotated, only lower calyx are seen, upper calyx is missing, and this is the drooping lily sign, right? So this is how an appearance is. This is what you have to know. MCU is mandatory for managing these patients. And treatment of a complete duplication will be completely and entirely based on the scenarios. Now, the patient is asymptomatic without scarring and normal function. What can be done? Asymptomatic patients without scarring and normal function. Incidentally diagnosed, for example, pain abdomen. Patient has mesenteric lymphadenopathy, and that is why pain abdomen, or ascariasis. And incidentally, it is found to have a complete duplication. You do the study, and you find that it is it's an asymptomatic patient without scarring, without any uh, problems in the function. So, as very nicely said, it is going to be a fit candidate for observation. We would observe this patient. But if there's an asymptomatic with progressive scarring, so progressive scarring means you have done more than one scan and you find that the number of scars are increasing, it's a progressive scarring, then obviously this is a good indication for you to start managing this patient. So we need some kind of a reimplantation, right? So remember, asymptomatic patient is asymptomatic, incidentally diagnosed, but he has a scarring. And then you probably waited for 6 more months and there is more progressive scarring. So this is a timeline. And these patients will also require implantation. This patient is asymptomatic, right? I hope you understand. These are both asymptomatic patients. Now we are talking about symptomatic patients. If symptomatic patients, then obviously you will do imaging and you find the ureters are not very dilated. If the ureters are not very dilated, you can do a common sheath reimplantation also, right? Many of the ureters which ultimately looks like they are separate, but they may have a common sheath, and common sheath is to be together reimplanted. And the question is why you should not be separating the common sheath, right? So what if only lower ureter is refluxing? Upper ureter is not refluxing. What do you do if only the lower ureter is refluxing and there is a common sheath, right? So please do remember that still we do go for a common sheath reimplantation also, and everyone knows why we do not separate the common sheath, because the vascularity of both the ureters are, you do not know. When you divide them, vascularity of one of the ureters may be jeopardized, highly compromised, and that may have problems in vascularity. It can cause necrosis of one of the ureters. So we do not separate. Very important. Again, I think last month only in our institute we had a case in which lower ureter only was the refluxing, but when we opened, it was a common sheath, and we end up doing a common sheath reimplantation only, right? The patient is symptomatic, but only one ureter is dilated. So we're talking about complete duplication, only one ureter is dilated. So how do we manage such cases? So we have different techniques of uh, reducing the caliber of the ureters, but the one which is my personal choice, even I think Quran also mentions it, that plication of the side wall is the one of the best methods. So plicate it, narrow the ureter, and reimplant it. Now, question is if this is both. I do not know how many of you have assisted your teachers, and both the ureters are dilated, hugely dilated. We sometimes have ureters which looks almost like a ileum of a maybe an infant. That huge. Now there are challenges. So how many of you have done plication? What's the problem if you do plication? I am sure Arvind will answer this. What is the problem?
Vascularity will get compromised.
What vascularity is going to compromise more if you cut, taper and resuture. So
Sir,
the problem,
problem of plication you mean, sir?
yeah, problem of plication. If you plicate, then what is the problem?
No, it
So
can again
Vivo,
spring back and
no,
recurrence.
Vivo has answered very correctly. Vivo has answered it nicely. And see, if you plicate it, it makes the ureter very bulky. Submucosal tunnel and then transport of the ureter through the subcutaneous submucous plane is very, very difficult because ureter becomes quite bulky. Now imagine both the ureters are dilated and you have to do plication of both the ureters. So it becomes extremely difficult to bring these ureters down. So it's very difficult to placate. These are some practical problems, and luckily Quran mentions what to do. So in these cases, if both ureters are there and there is no other choice. If you have to attain 3:1 ratio, you have to have a 3 times the diameter of the interstitial ureter. Then you have to taper. You have to reduce the diameter because you cannot have such a big length to create a submucous tunnel. So excisional tapering is better if both the ureters are there. Please do remember that alternate treatment is also there. If only one ureter is refluxing, then you can do ureterostomy. And I think one of Aditya has answered this. Now he has answered ureteroneocystostomy. Please remember that if only one ureter is refluxing, then you can remove this ureter and join it to the one which is non-refluxing. So by now, if I just stop and tell you, then can you see the number of permutation combinations with that? And many of you are going to probably face duplication by chance because your investigations have relied on an ultrasonography where the ultrasonographist's experience has not been to find a duplication. Many times, even a radionuclide scan, one has to be very careful. So many times it's an intraoperative surprise also, right? So please remember, we are dealing with the other problem of complete duplication in which there is an ectopia of the upper ureter. And everybody knows through the Wiegand-Mayer law that the ectopic ureter is the one which is connected to the upper pole, right? So you can have isolated ectopia without duplication, single ureter also having ectopia, but that is very, very rare. 20% only. 80% of all ectopic ureters are associated with duplication. Standard questions are there in males. It is above the sphincter, so they are continent, but they have problems. They have problems of reflux, they have problems of obstruction, upper pole is dysplastic, and the most common side where they open is the prostatic urethra. So every time the sphincter is going to close them. So their drainage is not good. So many of these males can present with an epididymoorchitis. You must know that epididymoorchitis in a male, right? Suppose the again open to everyone. And I think some of you are in the audiences who have taken rounds, I have already told them. If a child, a male boy, is having epididymoorchitis again and again, right? One episode, then after that, 3 months later, another episode, very difficult with antibiotics also to subside, but subsides and goes home. Then again, another episode, 2, 3 episodes per year. So, what should one suspect? So, today you must know, you must suspect ectopic ureter because they are not incontinent. You must suspect. There is another one which you should suspect. Repeated epididymoorchitis. It's not linked to this topic today. Yeah, vasal reflux. Yes, but you must remember that it may be a case of a stricture urethral stricture. So a UTI refluxing into, as Arvind said, it is causing. So you must remember a child, apart from tuberculosis, obviously in India, we must be careful that these are the two very important causes in a male. Then females, everybody knows you have to be very careful. And I think uh, even before imaging is done, in a female, you know that a girl who is coming and saying that I have a normal sensation, I fill bladder normally, I have sensations, I go and pass urine with a stream. But between the two episodes of voiding, my clothes are always wet with urine. So normal voiding with true incontinence is the hallmark feature of a complete duplication in a female. And in this, the lady is a truly incontinent because her ectopic ureter opens sometimes below the sphincter, sometimes into the reproductive tracts also. Sometimes it may be even visible if you do a good inspection of the introitus, good inspection of the vestibule, right? So ureteroceles are on next very important topic, and 80% of the ureteroceles are seen in females. It's more common on the left side. 10% of them are bilateral. And very important question, is ureteroceles are associated with the upper pole of the upper ureter. Again, this is very important. Like I said, VUR is more common with the lower ureter. Ureteroceles are associated more with the upper pole. Right? So classification. So classification is something which everybody must know, and classification is something which everybody is not taught in a daily day-to-day this thing. And one must know that there are two classifications. The one which is very commonly and loosely applied is actually the Committee on Terminology of the Urologic section. This is one of the classification which classifies ureterocele as intravesical and ectopic. Right? I want to know how many, if you can at least say two or three Douglas Stephens classifications of ureterocele. Any two, three names. Right? Even in the PSU also it was taught. So just two, three names only is sufficient enough. Right? So Seco ureterocele is one of the, yes, it is one of the, Anusha has said it, Aditya has said it. It is not the one which is very common one, but yes, it is one of the types. Right? So the classification actually says intravesical, extravesical, right? Then there can be a stenotic. Please note the incidences, it is important. That is why I said that today you are wise, but this lecture should make you wiser. So stenotic is 40%, it's a good amount of number. Another 40% will be sphincteric. There will be 5% less common, which are non-obstructed. There can be sphincterostenotic, that is a combination of stenotic and sphincteric. Pico-ureterocele, again less common, and there can be blind ureterocele also, right? So I just imagine that I'm on the other side and somebody is taking a lecture. If somebody has taught all this, then it doesn't make sense. So I thought, let's talk about it. Stenotic, what does it mean? Stenotic is a ureterocele which is located inside the bladder, and its actual opening is small, stenotic, and pinpoint. It's a pinpoint orifice. Whereas sphincteric, as the name suggests, it is wide and gaping, but it is located at the bladder neck and the urethra, right? And uh, it completely is dependent on the sphincteric action. So normally the internal sphincters are closed, so this will also close. So when the person is voiding, when the sphincters are open, that time it will empty. So this is a sphincteric ureterocele. Sphincterostenotic is the ureterocele whose orifice is both ectopic also and stenotic also. It is not very common, but it's a combination of both. So any problems here to understand it, right? Naturally, the sphincteric one will one which will prolapse down. It will go little down into the bladder neck. It has to come to the sphincter, right? Stenotic is the one which is completely into the bladder. Seco-ureterocele, people said, is a ureterocele whose orifice is in the bladder, but it is not a very common type, and it is unique because it has a tongue, and that tongue of the ureterocele may sometimes prolapse into the urethra, and sometimes it can be visible outside also. This is the seco-ureterocele. We have a non-obstructive variety also, and please remember, in this you put a cystoscope. It has happened twice or thrice in my case also. In my initial days, the imaging is showing ureterocele, but when I put a cystoscope, I don't see anything. But if you wait, then you will see an ureterocele developing when there is a peristalsis. That's a non-obstructive. And blind is the ureterocele, which is not connected to any pole, just an ureterocele. Some people call this as a diverticulum also. But no, embryologically it was connected once and now it is not connected anymore. This is known as a blind ureterocele, right? So anyone who is writing an answer on ureterocele, if you, this can be incorporated in your answer, this will be very nice. You know the common ones, sphincteric and stenotic. It should be mentioned in your and extravesical, intravesical should be mentioned. So very commonly asked question, how does a ureterocele commonly present? Prenatally, yes, you can diagnose them. And since the ultrasonic machines has significantly improved in technology and its sensitivity, therefore the diagnosis of ureterocele antenatally is also increased from 2 to 28%. 2 was hardly negligible and 28% is a quite a number. And obviously there will be a suspicion when the ultrasonography sees a hydronephrosis. If you see a hydronephrosis on one side, you will try to trace the ureter also, and then you go down and you can see a cyst inside the cyst as well. Our problems are mostly postnatal. Here our ultrasonography misses meningomyelocele. So leave aside ureteroceles. Theoretically, yes, but that's the kind of patients we are dealing with. So we are probably hardly very few cases we are going to have prenatal, but it is possible. Postnatally, how do they present? So can someone tell me what is the postnatal presentation most common of ureterocele? Is it obstruction? Is it bladder outlet obstruction? Is it prolapse? Is it reflux? Is it UTI? Which is the most common presentation of postnatal? So again, Aditya is super active. Tamujit is a very regular one. Yeah, hydronephrosis, no. So most common presentation of ureterocele is going to be UTI, right? Apart from UTI, there can be hematuria also, and hematuria is post-trauma. Patient can also present with a palpable bladder because ureteroceles which are big can cause bladder outlet obstruction. And girls can present also with a interlabial mass. And this is a very good differential diagnosis. If you have a reddish kind of a mask bulging out from the labia, so one can be a prolapsing ureterocele. Can someone tell me what it can be, the other thing in an infant girl? So urethral prolapse, botroid. Very who is this? Regenia, very good. So botryotomy. It can be a rhabdomyosarcoma. Mother who has been on a estrogenic some exposure. So botroid tumors can also have a prolapsing like this. So one has to be very nice. Arvind has answered first. So Arvind being a post MCH, your answer does not matter much because I think I do not know Regenia is student or not, but definitely. And ureterocele one has said it can also have prolapse and have a reddish erythematous. I have seen once in my life, and it seems very strange. And you can have all sorts of things in your mind, but that is the ureterocele which can protrude out, right? So a picture from Campbell. This is how next time you have you must have two differential diagnoses. One is definitely ureterocele, right? So how do we diagnose ureteroceles? So traditionally, the triad of investigation would include an ultrasound, an MCU, and a renal scan. But if you all understand, ureteroceles are not going to be isolated. It has to be with duplex. And if it is with duplex, then you must know a good anatomy of the ureters, incomplete or complete, dilated or not dilated, and where it is inserting into the bladder. You can have all these informations nowadays. And if you need more investigations, then IVP is obsolete. MRI has replaced CT scan. MRI is the one of the investigation of choice. If you need a detailed investigation. Yeah, so imperforate hymen, Tamojit has said, yeah, that can also be one of the differentials, right? So MRI is very, very important. Now, what comes here, I'll quickly put a star for all those who are going to appear for your theory exams. So if somebody is writing on diagnosis of ureterocele, one must tell what is the aim, what is the reason why you are investigating them, what is the information you require in a ureterocele. So please remember, number one, location is very important. If it is extravesical, it is ectopic, your challenge is different. If it is intravesical, your management is different. So location of the ureterocele will matter the ultimate treatment. Then very, very important, the status of ureter is very important, right? Whether there are two, whether it is dilated, not dilated, hugely dilated, it is very, very important. Associated with duplication or not, very important. Most commonly, ureteroceles will be associated with duplications. And most commonly, which pole? It is associated with which pole? It will be associated with upper pole or the lower pole. And very important, next is the amount of renal dysplasias. So Aditya has answered this also correctly. Renal dysplasia present or not present is very, very important. Right? So 4 aims of any investigation for ureterocele. And these are the investigations I've already mentioned. They will give these 4 answers. Right? Please note, MCU also has a lot of information you can collect from. It's a very, very, very important investigation. You must have a baseline whether there is a reflux or not. Right? So ureteroceles are associated with the upper pole ureter, but VUR happens. These data are from Quran, right? So if anyone has to answer in the exams, very confident you can say Quran says 50% reflux occurs in the lower ureter. Contralateral ureter is 25%. And MCU gives one more very important information which many of you may not know. Those who are studying for your exams, they know, and that is detrusor backing. It makes a hell difference whether you are going to easily be able to deroofing the ureterocele easily or not. Because if you have a thick layer of detrusor over it, then it is very difficult to sometimes decompress. So detrusor backing can be seen. It's a live test, right? Real-time test. So when you see the patient is training to micturate, you can see if it's a heavily backed by detrusor, the ureterocele do not bulge anywhere. But if you have a poor detrusor cover, it may bulge like a diverticulum. So this has an impact, and this many of you may not know, right? Now this, again, I put a star because ultimately you must know what is the principles of treatment. The principles of treatment, number one, is to preserve the renal function. Obviously, for any condition, we have to ensure that the renal functions are preserved. Then we have to ensure that there's an unobstructed flow of urine after management of the ureterocele. We also need to prevent VUR. We also need to prevent bladder outlet obstruction. And we need to prevent any bladder wall deficiencies, right? Especially if there is a diverticulum or there is a poor detrusor backing, right? If there is a detrusor poor backing, post management also there can be formation of a diverticulum. So one must, these are the principles of the management of a ureterocele. You can see there are 5 principles. So renal function has to be thoroughly, you have to preserve it. Repeating again that the flow of urine should now come to the bladder. Plus VUR should not be there, which is very difficult actually, but you have to ensure that. Plus bladder outlet obstruction is not there, and bladder wall dynamics is also preserved. So what are the treatment options with ureterocele? So you can have an endoscopic incision, which most of the institutions are doing. It is very simple. It is doable, but it has its challenges. We are going to deal with those challenges. Upper pole nephrectomy is one option. complete reconstruction at the bladder level. That means you excise the ureterocele and then reimplant the ureter in the same sitting. And sometimes you can go conservative. But please understand, this is also important. This is ureterocele is not the diagnosis where somebody has to jump into the treatment. One has to decide, and decision for management of a ureterocele decides on multiple factors. You must know whether it's an asymptomatic, symptomatic, prenatal, what kind of scenario and what kind of presentation is this, because the management depend completely on the type of the presentation. Age is very, very important, right? Ureterocele at a very is a prenatally diagnosed ureterocele will have more renal damage. So you have to show your urgency depending upon the age of the patient. Then intravesical and ectopic is going to be a challenge. So you must know. So that level of investigation you have to do so that you know what type of ureterocele it is. Then function of both moieties. I've already told in the beginning that function is very, very important. Function in a duplication for both the moieties. And the status of viewer is again very important. Can you see that there are again 5 factors which decides how we manage an ureterocele. So these are the 5 factors. Again repeating, these are from Quran. This was my favorite book for going for exams. In addition to this, you can be the wisest of all if you add to these notes other books, other CMEs. You can add, keep adding. You see some journals, you see some meta-analysis, you can add to this, right? So advantage of an endoscopic incision, there are disadvantages of an endoscopic incision. Advantage of an endoscopic incision is that obviously this is safe, this is simple, this is very quick, and you need a minimum hospital stay. There's no incision also. One must know that I'm going to talk in the disadvantage that endoscopic incisions will lead to VUR. But nonetheless, this is a stopgap procedure for very small babies where you cannot do a ureteric reimplantation. I want to know from this class why in a 2-month-old baby we cannot reimplant or we should not reimplant. Right? In an infant, why is reimplantation may be difficult? It is doable, but why it is difficult? My guess is Aditya is going to answer it first. No. So Sheikh, yeah, very nice. So yes, so you do not have that big a bladder where you can make a mucosal tunnel to adequate length. The ureters are quite dilated and you do not find that much length. Plus, the bladder wall thickness is not that much that you can create safely. Ureters are also quite friable. They are liable to much more injuries. There can be uh, problems in their vascularity. So very nice. So you should avoid a ureteric reimplantation in infants. So you want the bladder to grow, right? So advantage number third, and these are all your advantages, that if you do an ureterocele incision by endoscopy, the ureteric diameter will definitely reduce over time. Even if later on you have to do a reimplantation, the diameter will reduce automatically because you have removed the obstruction. Sometimes you may not even need to do a tapering, right? Sometimes ureterocele can cause reflux, in which again I'm repeating. So I want one knowledge to always go with you, that ureteroceles are associated with the upper ureter, but sometimes ureterocele can cause reflux in the lower ureter also. And if you give an incision, it can reduce the VUR in the lower ureter. But there are problems of endoscopic incision. If you have ureterocele originating from the urethra, the mucosa which is going to a flap is going to be created when you give an incision. This flap can cause urethral obstruction, especially if the ureterocele is coming into the bladder neck. If you give an incision, so that mucosa forms like a flap and it will be causing bladder outlet obstruction. And there's a very, very high chance that VUR may develop. Again, this lecture is not meant how do we do an endoscopic incision. That is a different thing altogether. But this is just a perspective What are the advantages, disadvantages when somebody is going to do that surgical technique? Yes, we give an incision at a place, we make it a smiling incision. We try our best that there is no reflux, but there is a very high chance of reflux post endoscopic incision. Another management of ureterocele is an upper pole nephrectomy. And upper pole nephrectomy is best. So should I take the questions later on? Okay. Degestant post UI? No. I don't personally put it. It's not recommended in any of the books also. Right? So why you do not need a degestant is that the whole system on that side is on a very high pressure. And when you give an incision, that incision, if it is wide and good enough, then it does not close because it keeps draining, because it is under a lot of pressure. Right? And which is very rarely heard of if you give a good incision that it will again stenose. It can be possible, but less. Right? So partial nephrectomy, especially when the upper pole is poorly functioning. But if suppose it is a good function, then please remember you can do a ureterostomy. We do not need to do an upper pole nephrectomy. Right? So again, therefore, the function is very, very important. And you can straight away go for a bladder-based reconstruction also. That means you are removing the ureterocele and then doing a reimplantation also. But as I told you, that cannot be the first procedure, especially. That is why, have you noticed that we have spoken about the factors which decides the management. So please see age is one of the factors which decides. So ureterocele is not something where we jump with a head which is very hot and an impulsive surgeon and doing one kind of a management. So it's a very thought of management. One needs to know these factors before managing an ureterocele. Right? So do remember that, especially when talking about infants, it may be challenging. But if the same is 5 years, 6 years with an adequate bladder, volume is good, then you can go for straight away resection of the ureterocele and reimplantation as well. Right? Which brings us to the very important, some things which I want all of you to remember. Most of your short notes you can manage through here. Right? Most of you should not feel from which, what is the source? The source is Quran. Some parts of it has been augmented by Campbell. So if I ask you what are the 3 challenges in an incomplete duplication, usually they are asymptomatic. Right? So what are the 3 challenges which incomplete duplication patients will have? Right? We have done that. And the 3 challenges in an incomplete duplications would be VUR, UGO obstruction, and yo-yo phenomena. Right? These are the 3 problems which you have to probably manage. Right? So ureterocele, if you have to remember associated with which ureter. So this you cannot forget. This has to be upper ureter. Right? VUR is common in duplication corresponding to which ureter. And why? Because the lower ureter goes more lateral. It's a lateral ectopia. It goes more laterally and cephalic. And that is a less interstitial course. Right? PUJ obstruction is common in which moiety? So again, one must know these upper, lower, these are very important. So PUJ obstruction in a duplication is more common in the lower moiety. Right? So if a ureter is here, then this will be the lower ureter. Right? Agreed? This will be the lower ureter. And if the ureter is here, this will be the upper ureter. And no problems about it. This is going to be a lateral ectopia. This is going to be a caudal ectopia. This is predisposed to VUR. This is predisposed to obstruction. Obstruction and incontinence. Right? You must all remember the classification of ureterocele. You must now, instead of saying seco-ureterocele, you should say the ones which are 40% incidences. Right? If somebody asked you that the treatment of an ectopic ureter with a good upper pole function, without VUR, very nice. It has to be treatment of an please remember that no treatment is not an option. This patient has issues. This patient is symptomatic patient. So if it's a good function, so anything less than 10% is a poor function. Anything more than 10%, some books have 15%. You should be salvaging that moiety. And if the function is okay, then you can do an ureterostomy. Right? So I did not promise to make you the wisest and the best in duplication, but yeah, definitely you have to be wiser in duplication. Little bit of embryology, little bit of clinical scenarios, methods. Book is Quran, augmented by Campbell. You can ask questions. I'll be happy to answer them. I can take the chat box if anyone has any questions. If you have, you can ask.
Thank you, sir. Thank you for the session. Now, anyone with questions can type your question in the chat box.
Thank you so much, sir. So rest assured, Kanishka sir is also here, and this would be relevant the day you are going to diagnose a ureterocele in your clinical practice. Please do not manage an ureterocele without a search for knowing the anatomy of and expect that it will be a duplication. Next time there is repeated episodes of epidural orchitis in a boy, you must know that okay, stricture urethra is one. Another one may be an ectopic ureter which is there, which are very prominent. UTI in girls, multiple episodes in a year should raise your suspicion. It should be so. This is how you, and recently also it happened. I was called that pylolithotomy is being done, and during pylolithotomy, it is found that there is a uh, ectopic or there's a duplication. There's an upper fold also. So one must know this knowledge is important to know what to do then. So like I said, that suppose there is a PUJ obstruction and the lower ureter is very short. So you must have this versatility and the flexibility to be able to do a pylostomy. That means you are going to combine both the ureters. So why today I must tell everyone there is a good number of 55. See, out of all the surgical branches, there is no doubt that pediatric surgery is the best of the best, and only we can market it. It is the best branch because we deal with variations. We are artists. Every day we are doing artistry. We are not following a set procedure of TURP. Every case is unique. Every duplication is unique. Every TEF is different. Every urological anomaly is different. There is a surgeon who is using his imagination to manage the patient, right? Because the congenital anomalies are beyond us. And pediatric surgery is, to my this thing, is one of the best branches you all have chosen for yourself, right? And you must go forward with this morale and then interact with your juniors. It is the best and it will remain the best, and the curve can only go higher and higher. It may be a gentle rise, but definitely not like many of the other branches where there's a steep rise and a steep fall. right? So all done. So
I think there are no questions, sir.
very nice. So proud to be a pediatric surgeon. Thank you so much. It's a very good initiative. I hope
Thank
I
you.
can talk to. Yeah, yeah. Thank you so much.
Thank you, sir, for wonderful session.